Good evening to all. And at the outset, I would like to invite all of you from the Cochin Hematology Group for this evening webinar. And it's great pleasure for me to invite Dr. Nitin, who does not need any introductions in our forum. And not only in our forum, in the hematology circle and in India. And we are proud Nitin being within our countryman. So I would like to invite Dr. Nitin to take over without wasting the time, as he is having a short time schedule for us. So Dr. Nitin, please take over. Then subsequently, if time permits, we can have your excellent expert opinion on our discussions.
All right. Good evening, everyone. Thank you, Dr. Ramaswamy, for the kind introduction. So let me share my screen here. You guys can see the screen?
Yes.
Okay, perfect. Yeah, so good evening, everyone in India. It's morning here in Houston, and I hope everyone is doing well with all the COVID happening in India. I hope you and your family, everyone is doing okay. I'm sure you guys are busy in the hospital with the COVID issues right now. So, next, maybe in the next half an hour, 45 minutes or so, I will go over this slide deck to review how we use BTK inhibitors in the management of CLL. Certainly, the talk is on a perspective from how we manage things in the United States, but I will, obviously in the discussion part, we can discuss how you guys are doing things in India in terms of the management of COVID, in terms of the management of CLL. So these are my financial disclosures. So just at the outset, I think it's important to highlight that the therapy for CLL has changed remarkably. So previously, up until I would say year 2000, before the introduction of rituximab, really therapy was single agent, alkylating agent, purine analogs, then the combination of fludarabine, cyclophosphamide, bendamustine came along, and then these regimens such as FCR and bendamustine rituximab were developed. And they were really quite commonly used up until recently. In the last 5-6 years, now we have several BTK inhibitors, at least 2 of them approved for CLL, ibrutinib and acalabrutinib, and we'll talk about those. PI3 kinase inhibitors, BCL2 inhibitor venetoclax, and also obinutuzumab, which is a novel CD20 antibody. And there are other BTK inhibitor, zanubrutinib is coming along. We'll briefly talk about that as well. And then other PI3 kinase inhibitors such as umbralisib is also coming along, should likely be FDA approved this year for CLL. So at least what has happened in the United States is that with all these therapies, we have really moved away from chemotherapy for patients with CLL. I know, in India, I think chemotherapy is still the most commonly used probably regimen just because of the cost and other issues, but at least in the United States, we have moved away. So, and I think what has happened is that we have moved away from chemoimmunotherapy era, where at that time, some years ago, FCR was given for young fit patients, and you would do bendamustine rituximab or chlorambucil as therapy for older adults, to this targeted therapy era, where at least in our center, we are using FCR for really a very selected group of patients. So which are young and fit. So that I would say maybe less than 65 years of age, no major comorbidities, IGVH mutated. So these are the patients who are IGVH mutated, and then do not have any TP53 deletion, TP53 mutation, or deletion 17p. And if you look at it, that group only constitutes around 10% of all patients with CLL who need therapy, because the median age of diagnosis of CLL is like 70, 72 years. And by the time they need treatment, average age is like 74, 75 years. So majority of the patients are not in this group. So for the remaining 90% of the patients, really targeted therapies have become the standard of care for patients with CLL. And I would also say that at our center, we have not really used FCR, I think, for several years now. We have a new regimen we have been exploring in clinical trials called IFCG, but that's the only clinical trial we have right now with chemoimmunotherapy. But practically, I think right now, 95+% of patients at our center for CLL are getting non-chemotherapy approaches. So what is the standard of care right now for frontline therapy for CLL? So if you, first of all, you need to meet the typical IWCLL treatment criteria. You cannot start a patient on day one with Rise stage 0 CLL on a BTK inhibitor because you just want to treat it. You have to have the treatment indications. If you have that, then you'll see if the patient has a deletion 17p or p53 mutation. Now, I would say that 17p deletion is frequently checked for patients, at least in the United States, I'm sure in India as well. But TP53 mutation is not commonly tested, also in the United States at majority of the centers. And I believe this is something which we should be doing routinely. Obviously, it's available in most of the next generation sequencing panel. And I think this should be done because you will pick up additional patients who are del17p wild type, or they don't have del17p, but they have a TP53 mutation. So if you have those patients should get ibrutinib or acalabrutinib. Venetoclax plus obinutuzumab for this group of patients has not shown to be beneficial long-term. I will show you some data. If you do not have that, and patients are young and fit, no major comorbidities, IGVH mutated, then you can do potentially FCR as we discussed before, ibrutinib, acalabrutinib G, or venetoclax G. If patient is unmutated, or any older patient, or comorbidities, comorbidities, the three frontline targeted therapies, again, ibrutinib, acalabrutinib, and venetoclax G. So this is the standard kind of practice, I would say, outside of a clinical trial setting at our center. So the focus of this talk is a BTK inhibitor. So I'm going to spend the majority of time on BTK inhibitors and then briefly towards the end talk about some venetoclax-based strategy. But so we have at least 3 BTK inhibitors approved. Ibrutinib is approved, acalabrutinib is approved. They're both approved for CLL. Zanubrutinib is also approved, not yet for CLL, but other lymphomas, and hopefully will get approved as well. So what you see here is the kinase profile where ibrutinib hits BTK, but it also hits several other enzymes. Zanubrutinib is slightly more selective, and acalabrutinib appears to be the most selective among the 3 in terms of the kinases is hit. And its relevance is that and we'll talk about this, some of the side effects of ibrutinib may be coming off these off-target effects, which ibrutinib inhibits. But acalabrutinib and zanubrutinib are they don't inhibit those kinases as well. So maybe that's why we are seeing less toxicity with these second generation drugs. So ibrutinib is the first generation BTK, acala and zanubrutinib are the second generation BTK inhibitor. And then there is also a third generation LOXO 305, which is in clinical trials right now. So let's look at the actual clinical data. So very briefly about ibrutinib. So ibrutinib approval in the frontline was because of this trial called RESONATE-2 trial, which was ibrutinib versus chlorambucil. And recently, Jan Berger from our group reported 5-year data where in the frontline setting, if you just give ibrutinib alone without anything, 5-year PFS was 70% compared to chlorambucil, which is obviously much inferior. So this is a number many times patients ask me what to expect in future. So I tell them ballpark, 5-year PFS of 70%, that you'll be doing well on therapy without progression kind of thing 5 years down the line. Ibrutinib has also been tested in this large study called Alliance study, because one of the criticism of the RESONATE-2 study was chlorambucil was the backbone, was the control arm. And at least in the United States, chlorambucil is not really used for patients with CLL. So this study was designed where the backbone is bendamustine rituximab, which is, or the control arm, which is a very appropriate comparison because BR is probably the most commonly, up until recently, the most commonly used chemotherapy regimen, more commonly used than FCR for patients with CLL. So this trial randomized patients ibrutinib rituximab versus ibrutinib versus bendamustine rituximab. These are generally older patients with CLL. And 2 points here, both the ibrutinib arms were superior to bendamustine rituximab. So if you want your patient to have a long progression-free survival, certainly ibrutinib is better than BR. And the second point here is that there was no benefit of adding rituximab. Obviously, using rituximab is just like something obvious. We do it for everything, in B-cell lymphoma, CLL, but it appears that in combination with ibrutinib, there is no benefit of adding rituximab. So we don't use rituximab at all, or we don't add rituximab when we are using ibrutinib for our patients. So now let's some time on acalabrutinib. So acalabrutinib, as I mentioned before, is a new BTK inhibitor or a second generation BTK inhibitor. And the trial which led to the approval of acalabrutinib in CLL is what is called ELEVATE-TN study. So this is a study which was, again, designed for older patients. You can see generally patients upwards of 65 years of age. And they were randomized into 3 different arms: acala G versus acala monotherapy versus G chlorambucil. So there were 3 different arms in the study. Just to kind of highlight some of the baseline characteristics of these patients, the median age was 70 years. So again, we are treating older patients in the study, which is typically the age of CLL patients, which are seen in the practice. Other characteristics were kind of balanced across the arms. And this was the primary endpoint. So at 2-year mark, both the acalabrutinib arms were superior to chlorambucil arm. So clearly, acalabrutinib is the way to go as part of this trial. But intriguingly, there was a 6 percentage point PFS difference in favor of acala plus obinutuzumab as opposed to acala alone. So, and this was actually, if you look at the hazard ratio of acala G versus acala, it was 0.49, and the hazard ratio was not crossing 1, indicating that this may be a statistically significant difference, but it's only a 6 percentage point PFS difference. Adding obinutuzumab certainly adds to infusion reaction, cost, neutropenia. So I think a longer follow-up of this study, like a subsequent 3 or 4 year follow-up, will be essential to see how these curves play out. And we're hoping to have that result this year. When they look at the kind of different subgroups, high-risk subgroups of patients, the benefit was seen across, and I think no real surprises here in terms of favorability of acala G and acala versus G chlorambucil. And then again, as is true for BTK inhibitors, majority of the responses were partial remissions. And that is true for ibrutinib, this is true for zanubrutinib. You can get some complete remissions, but practically most of the responses with these drugs will be partial remissions. And again, that's what was seen here, 85% versus 81%. So high rates of overall response rate, again, which is consistent with what you see with BTK inhibitors. As is true with most studies with CLL, there was no OS benefit. It's difficult to show OS benefit in studies with CLL because obviously patients live long term and you have to wait a long time to see if there is an OS benefit. Also, as is true with many of these studies, if you fail G chlorambucil, you can cross over to acalabrutinib, and therefore you kind of nullify the OS benefit, which may have appeared if the patient was not crossed over. The other important thing you want to look at is the safety profile of acalabrutinib. So this is the kind of toxicity profile of acalabrutinib, G, acalabrutinib alone, and G chlorambucil. What you see here, again, as I was mentioning before, if you add obinutuzumab, you add some myelosuppression, grade 3 or 4 neutropenia of 30% as opposed to 10% if you use acala alone. So certainly, that would be there. But the most important thing you want to look at whenever you're looking at a BTK inhibitor trials are these events of clinical interest. So which is atrial fibrillation first and foremost. So around 3.4% in the acala G and 3.9% in the acalabrutinib alone. So I would say 3.5 to 4% of patients will develop atrial fibrillation, or at least in this trial develop atrial fibrillation with the use of acalabrutinib. Again, hypertension in a small number of patients. Major bleeding was rare, infections were there, but again, these are something which we see in patients with CLL. So overall, this risk of atrial fibrillation appears to be lower than what has been noted with ibrutinib, where upwards of 10 to 15% of patients can get atrial fibrillation when you're using ibrutinib. So this was the trial which led to the approval of acalabrutinib with and without obinutuzumab in the frontline setting in the United States. Now, recently, some other data has been published with acalabrutinib as well. So the trial I just showed you, the median follow-up was like 2 years. So, but what is the longer follow-up we know for patients? How do patients do long-term with acalabrutinib? We have that data with ibrutinib, but now the data is emerging with acalabrutinib as well. So this is a study, 99 patients, frontline CLL, median age of 64 years, and this follow-up is now 4.5 years or so. So first of all, everyone achieved a remission on the study. This is the waterfall plot for the lymph nodes, and you can see, everyone had a response, lymph node reduction on this study with acalabrutinib. And this is the 4-year PFS of acalabrutinib in these patients. So again, this looks actually pretty encouraging. You have a 4-year PFS of 96% for these patients. So this is a frontline patients getting acalabrutinib single agent at several clinical centers in the United States. 99 patients were enrolled. And you can see a really nice durability, long-term durability of these patients. So again, another thing you want to look at the atrial fibrillation rate. So because atrial fibrillation, the longer you follow a patient, the more likely you may capture more events of atrial fibrillation. So here in this trial, the median follow-up was 4.5 years. And in 4.5 years of follow-up, 5 patients out of 99 patients develop atrial fibrillation. So the rate, again, around 4 to 5%, which again, as I mentioned previously, better than what we have noted with ibrutinib at similar time points of follow-up. So what's happening with acalabrutinib in terms of another important study is was called the head-to-head study of acalabrutinib versus ibrutinib. So this is a large study, 533 patients, where patients were randomized in the relapsed refractory setting, acalabrutinib versus ibrutinib. So this is a head-to-head comparison. There was a press release issued by AstraZeneca a couple of months ago, and hopefully they will present it either at EHA or ASCO, I'm not sure, but hopefully one of those meetings in next month, where the press release stated that the primary endpoint was PFS, non-inferiority of PFS of acala versus ibrutinib, which was met. So acala was non-inferior to ibrutinib. And the key secondary endpoint, which is the atrial fibrillation, was statistically less common with acalabrutinib versus ibrutinib. But that's the only thing we know publicly right now. So I think hopefully once the actual presentation comes out, hopefully next month, we'll know more about the details of what really happened. But that's a head-to-head trial. At least we know it was equally effective with less risk of atrial fibrillation compared to ibrutinib in a head-to-head trial. Now, acalabrutinib was also looked at in this large pooled analysis reported by Jennifer Brown, where one of the things the investigators wanted to look at the cardiovascular side effects. So what they did was they pooled together 762 patients from different studies where patients have received acalabrutinib. And these were different studies in CLL, including the Elevate study, which I kind of mentioned to you about. And then they pooled together all these patients who received acalabrutinib. And again, just to kind of highlight one point here, 4% patients with atrial fibrillation. So again, that number is consistent across different trials, even this large pooled analysis that around 4% of patients can develop atrial fibrillation after acalabrutinib. And again, this, in their summary, what the investigator stated, again, that this 4% rate, which overall appears to be better than what you would have seen with ibrutinib for these patients. But again, I think when the head-to-head data comes out next month, hopefully we'll be able to compare in the same randomized fashion atrial fibrillation rate between acalabrutinib and ibrutinib, and obviously compare other side effects as well as efficacy between the two BTK inhibitors. To kind of talk about the third BTK inhibitor, which is also very important in the field, is the zanubrutinib, which is a BTK inhibitor, which is also like acalabrutinib, another kind of a BTK inhibitor. And I just wanted to show you kind of one trial from this for this compound. This is 109 patients, and all had deletion 17p. So this is actually just a trial for deletion 17p. Zanubrutinib was given twice a day. The median follow-up is short. Again, you want to look at the rate of atrial fibrillation, which were around 3% here in this study. And then you look at the PFS. Again, these are only del17p patients. So as I mentioned previously, del17p patients, in my opinion, should be treated with a BTK inhibitor. So again, this data looks encouraging. I don't think we can say this is any better or worse than what we have seen with ibrutinib or acalabrutinib. I think so that's consistent that these BTK inhibitors can provide durable remission for patients with del17p or p53 mutation. So I mentioned about a head-to-head trial of acalabrutinib. There's also a head-to-head trial of zanubrutinib versus ibrutinib, which is called the Alpine trial, which is also in relapsed CLL. There was a press release again issued by BeiGene recently, I think a couple of weeks ago, where they also showed that this trial was met its primary endpoint in favor of zanubrutinib versus ibrutinib. Again, we don't know all the details yet. Hopefully at EHA or ASCO next month, these will be presented, and then we'll know more about these. So that was kind of a discussion about BTK inhibitors. So we talked about 3 BTK inhibitors: ibrutinib, acalabrutinib, and zanubrutinib. And I think it suffices to say, based on what we know right now, that the second generation BTK inhibitors appear to be safer than the first generation, which is ibrutinib. Now, the other important trial, and again, I wanted to kind of give you a complete perspective in the frontline setting, is a time-limited therapy with what is called the venetoclax plus obinutuzumab trial, or the CLL14 study. Hello? Okay. So in this particular study, let's see if there is a Q&A. Okay. In this particular study, patients were randomized Okay, in this particular study, patients were randomized to receive venetoclax for 1 year plus 6 months of obinutuzumab, or chlorambucil for 1 year plus 6 months of obinutuzumab. And this was recently updated at the ASH meeting now 6 months ago. So these patients, the median PFS at 4-year mark was 74% for ven obinutuzumab. So these are the patients who basically get 1 year of therapy, then you stop their venetoclax, and this remaining part of the curve, the 3-year part, which is shown here, is without therapy. They're just being monitored. And what you see here is that the curve, it has a slope to it. Patients are slowly relapsing. But again, this is a long treatment-free period for majority of these patients. And it's still at 4 year, 74% are progression-free. Now, one thing I mentioned is that for patients with deletion 17p or p53 mutation, this may not be the right strategy. Why that is that there were 25 patients in this study who were deletion 17p or p53. And that's the curve here, this blue line here. And what you see here is that when they stop therapy at 1 year mark, you see kind of these progressions in this step ladder kind of a pattern here. So these patients are progressing after you stop their venetoclax. If they did not have p53 mutation or deletion, then they are doing well. So based on this 25 patient study, or 25 patient cohort, I should say, the argument has been that these patients probably need BTK inhibitor, because I showed you previously the data with zanubrutinib, and the similar data is available with ibrutinib and acalabrutinib, where they can get durable long-term remission with a BTK inhibitor. So at least in the frontline setting in the United States, we now have three approaches: ibrutinib, acalabrutinib, which again is with and without obinutuzumab, you can use it, and then venetoclax is typically combined with obinutuzumab. There are pros and cons of these approaches, and this is something I discuss with my patients in the clinic. If they're not going on a clinical trial and they want to get a standard therapy, ibrutinib obviously had the longest track record, but it's an indefinite therapy, low rates of CR, and then atrial fibrillation rates are high. Acalabrutinib has less off-target effects, so it overall is better tolerated than ibrutinib, less dose reductions, less risk of atrial fibrillation compared to ibrutinib. And the venetoclax obinutuzumab certainly has an advantage of being time-limited therapy, but then we don't have long-term follow-up of this data. You have to watch for the tumor lysis syndrome. Obinutuzumab is given IV, so you have to get them to the hospital or the clinic to get it. Neutropenia rate is high, so you have to watch for infections, or many times they need growth factors, GCSF support. And then the P53 patients, as I mentioned in the previous slide, do not do well with this therapy. So now looking at some kind of future directions in the last maybe 5-7 minutes is we talked about therapy as BTK monotherapy. We also have these doublets, BCL2, which is venetoclax plus antibody, acalabrutinib plus obinutuzumab. But we and others have started to look at now doublets of BTK plus BCL2. And also the triplets are coming along where you kind of all three classes of drugs, you mix them together. So let's briefly look at it. So we have been working on this combination of ibrutinib plus venetoclax for patients with CLL. And we reported initially this data in New England Journal a couple of years ago, but this was an update presented at ASH and subsequently, hopefully will be published soon. In this, we treated 80 patients with ibrutinib plus venetoclax. So there is no antibody here, 2 oral drugs. And what we did was, first 3 months was ibrutinib alone, and then the patients added venetoclax. And then the venetoclax plus ibrutinib combination continued for a total of 2 years. And then we did serial bone marrows on these patients, and these are all intent to treat analysis, 80 patients. So serial bone marrow, so what you can see here is that at 1 year mark, 56% were MRD negative on an intent to treat, 66% at 2 year, and as a best response, 75% of the patients were MRD negative in the bone marrow with these 2 doublet regimens, 2 oral drugs without any need for antibody. So that seems pretty encouraging for patients that you can achieve such a depth of remission in large number of patients with 2 oral drugs. And this has been now confirmed by the large Captivate study, which is kind of a similar trial design, but much larger international study, where again, patients get the same thing, 3 months of ibrutinib, then you do the combination of 1 year, and then they have some randomizations based after that, but let's not go into that right now. But it's suffice to say, when you do this regimen for 1 year, and they treated 164 patients in the series, 75% in the blood and 68% in the bone marrow were MRD negative. So again, this is a large international study, again, confirming very similar data, what we reported from MD Anderson single center study, that you can achieve high rates of remission in a time-limited therapy with the combination of ibrutinib plus venetoclax. Now, very quickly, the other thing which is happening now is this triplets. Again, these are early data. What triplet basically is, you have a BTK inhibitor. So a couple of studies are looking at ibrutinib. There's a study with acalabrutinib, and there's a study with zanubrutinib, and you combine them with venetoclax plus obinutuzumab. So that's kind of a triplet studies. Everything has Ven-G in it, and then you choose your BTK inhibitor. Small number of patients. The follow-up also of these studies has been relatively short right now. But overall, I think, again, high rates of MRD remissions we are seeing. Whether these are better than just the doublet of ibrutinib plus venetoclax, that's something we don't know right now. I think we need to get more number of patients treated with these drugs, with these triplets. We need a longer follow-up of these data to see whether you need triplets or you can just do very well with 2 oral drugs such as ibrutinib plus venetoclax. And some of these data will come to us hopefully in the next couple of years. What this slide shows is a first-line phase 3 trials currently happening in the CLL field. And many of them are actually have fully accrued. We're just waiting for the results. And then if you look at, they have a control arm. Control arm has been chemotherapy. And then they have a variety of randomized arms. For example, the UK FLAIR study, a very large study, 1,500 patients. Patients are randomized to FCR versus ibrutinib rituximab versus ibrutinib alone versus ven plus ibrutinib. So again, this trial will help us know whether you need this doublet is better than single agent ibrutinib. CLL13 study looking at the chemo versus Veng versus Ven-R versus the triplet. And again, this study I'm actually looking forward to because this is probably the only study which is looking at Ven-R as a randomized arm. We always think of obinutuzumab being superior to rituximab based on the CLL11 study where the combination was with chlorambucil. But we haven't really proven that in the context of new drugs that whether rituximab or obinutuzumab is better than rituximab. But in this study, there's a head-to-head comparison, so we'll know more when this result is out. Similarly, this particular study, chemo versus acala-ven, so double, 2 oral drugs versus the triplet. So again, we'll see that. And then if you look at the more recent studies, these are studies which are ongoing right now, where actually they have gotten rid of chemotherapy completely, no more chemotherapy. And then patients are being compared to ibrutinib versus other combination strategies. So again, these studies they have not been reported yet. So I think I'm hoping that some of them will be reported in the next 1 to 2 years. And again, some of these comparisons will be very informative to see what is the ideal combination for these patients. So my second to last slide here, just kind of looking at the frontline therapy for CLL, you see that we do already have BTK inhibitor, so like ibrutinib, acalabrutinib approved, with and without antibody. We have BCL2 inhibitor venetoclax approved with antibody. But these combinations are happening, doublets, 2 oral drugs, or triplets. So we don't know which is the best one. Kind of the time will tell, but hopefully these randomized trials will help clarify. One of the other things when we're talking about target therapy, time-limited target therapies is what is the ideal duration? Should we do treatment for 1 year or 2 years, or should be MRD based? So that's something which is not clear right now. Trials are looking at different duration of strategy. So we'll see how the results pan out. Because one of the things you have to realize is that when we were using FCR, when we're using bendamustine rituximab, it was a time-limited therapy of 6 months. And then you obviously stop the therapy, you see what happens to the patient. If they relapse a few years down the line, you can use the same thing again. But then came the BTK inhibitors, where the goal was, oh, you need to give these therapies for the rest of their life. So now the field is kind of dialing back to say, hey, yes, we need to use the target therapies, but can we cut back? Can we develop a time-limited approach again as we were doing it in the era of chemotherapy? So in conclusion, hopefully I have kind of showed you data with second-generation BTK inhibitor with acalabrutinib, which appears to be equally effective, at least based on the randomized study. Again, we don't know all the data, but based on cross-trial comparison, it appears to be equally effective and safer than ibrutinib. And again, as I said, the head-to-head trial data is awaited. And then there are lots of kind of combination strategies happening right now in clinical trials, including many in phase 3 studies, which are still awaited. And I think it will help decide how we manage patients with CLL in the next few years to come. So thank you for your time and attention. This is my email address. If you guys want to reach me out later, please feel free. I'm always happy to answer questions or discuss things with you guys. And we'll open up for, I guess, the next part of the symposium. Thank you.
Thank you very much, Dr. Nitin. There are a few questions in the chat box. Before that, we have some few national faculties, and then after that, we can have a chat box discussion and a further discussion on the BTKi. So to continue our symposium, I would like to invite my national faculty, The first speaker is Dr. Lata Abraham from Cochin. She is currently head of the department in hematopathology in Rajagiri, and she is going to enlighten on the defining the high risk CLL. Conventionally, we will go by the clinical risk stratification most of the time. Now, if you go by the various IPA prognostic score or where most of the some of the few scores which has come up, they are including a lot of the new genetic tools for the categorization of the high risk to decide to define the treatment. Even they may not clinically fit enough to start the treatment. So whether to start or not, that will dilemma will be coming into our clinical day-to-day practice. Dr. Lata, over to you.
So good evening. I hope I am audible.
Yes, ma'am. Yes.
So after this highly informative and elaborate talk on the treatment of CLL, I will quickly rush through my topic, the risk factors associated with CLL. As we all know, diagnosis of CLL requires presence of more than 5,000 B lymphocytes per microliter in the peripheral blood, which is sustained for at least 3 months. These leukemic lymphocytes are small mature lymphocytes surrounded by a thin rim of cytoplasm and having inconspicuous nucleoli and irregularly clumped chromatin. Another characteristic feature of CLL is the presence of a good number of smear cells, which are mechanically disrupted or smeared out cells, because these neoplastic cells are more fragile compared to normal lymphocytes. Though CLL is considered together with SLL, the diagnosis of SLL requires presence of lymphadenopathy or organomegaly, and the lymphocyte count in the peripheral blood should be less than 5,000 per microliter. And the presence of less than 5,000 lymphocytes per microliter in the peripheral blood in the absence of lymphadenopathy, organomegaly, or cytopenias associated with the disease with bone marrow infiltration is diagnosed as monoclonal B lymphocytosis. The key diagnostic method for CLL is immunophenotyping. The neoplastic cells characteristically express the surface antigen CD5 along with the B cell markers CD19, CD20, and CD23. And the expression of CD20 and surface immunoglobulin is characteristically dim, which is helpful in the diagnosis of CLL. Immunophenotyping is helpful in differentiating CLL from other mature B-cell neoplasms, including mantle cell lymphoma, follicular lymphoma, marginal zone lymphoma, etc. Of this, the closest differential diagnosis is mantle cell lymphoma, where the cells are also positive for CD5. But in this case, the neoplastic cells are negative or dim for CD23, and they show bright expression with CD20 and surface immunoglobulin, which is helpful in the differential diagnosis. Coming to the risk factors in CLL, regarding the sex incidence, it is almost twice as common in men than in women, with a sex ratio of up to 2:1. Incidence is also higher in Caucasians, and it is lower in Asian populations like China and Japan. A family history of malignancy is another risk factor for CLL. Though originally considered as an indolent disease, CLL has a very heterogeneous clinical course with survival ranging from 2 to 20 years. So till the mid-1970, there were no definite clinical criteria that allowed separation of those patients who had a poor survival from those patients with an excellent prognosis. Later, several scoring systems were proposed by investigators around the world, including the RISE system and BINET system, followed by the MD Anderson Cancer Center nomogram, the German CLL study group prognostic model, and finally the CLL International Prognostic Index. Of this, the RISE system, which was more commonly used in USA and India, and Binet system was more commonly used in Europe. Both these systems categorizes patients into 3 risk groups. It is based on physical examination and CBC alone. The International Prognostic Index is the most widely used scoring system in clinical management. It combines genetic factors in addition to the clinical parameters, and it takes into consideration 5 prognostic indicators, independent prognostic indicators, and each factor is given a specific score, and the cumulative score is according to the cumulative score, the patients are categorized into 4 prognostic groups. And this International Prognostic Index is superior over the MD Anderson nomogram in that it combines both clinical parameters and genetic factors, and it is found to have a better prognostic value in assessing the risk of CLL patients. The time to first treatment and the overall survival can be predicted from the CLL International Prognostic Index stratification system. In a low risk group, the probability of remaining free from therapy at 5 years is around 85%, whereas in higher risk group it is only around 30 to 40%. And regarding overall survival also, the very high risk group has got a very low survival compared to the low risk group. The last 3 decades has also generated a plethora of prognostic biomarkers in CLL, including the serum markers like thymidine kinase, beta-2 microglobulin, lactate, dehydrogenase, lymphocyte doubling time, immunophenotypic markers like CD38, ZAP70, CD49D, IGHV mutation status, chromosome aberrations, gene aberrations, and microRNAs. All these factors have got definite role in assessing the risk in CLL patients. In addition, deletion 70p or TP53 mutation is also known to have a role in predicting prognosis to specific therapy. The other predictive biomarkers are NOTCH1 mutation, CD49D immunophenotypic marker, and IGHV mutation status. Complex karyotype and microRNAs are also known to have predictive value. Chromosomal abnormalities have given further insight into the disease progression and prognosis and is of major consideration in developing treatment. The most common chromosomal aberration in CLL is 13q deletion, which is associated with a favorable prognosis. The worst prognosis is for 17p deletion, followed by 11q deletion and trisomy 12. About 60% of CLL patients harbor IGHV mutation and is associated with a good prognosis. The other 40% having an unmutated IGHV mutation status is associated with adverse prognosis. Other adverse prognostic factors include NOTCH1 mutation, ATM mutation, and TP53 mutation. Based on the presence or absence of IGHV gene mutation, the CLL patients are classified into mutated and unmutated CLL, and these Kaplan-Meier survival curves indicate the aggressive course of unmutated CLL compared with the mutated CLL. TP53 aberrations can occur in both unmutated and mutated CLL. The TP53 aberrations include both 17p deletion and TP53 mutation. The most common type of TP53 aberrations include a combination of TP53 mutation and deletion 17p. It accounts for about 2/3 of all TP53 aberrations. And TP53 aberration that is associated with an aggressive course with a reduced overall survival and an increased time to first treatment. And TP53 mutation can also occur in the absence of deletion 17p, and when it occurs alone, this is known to have an independent prognostic factor in assessing response to fludarabine and bendamustine based chemotherapy. The overall survival rate is also very poor for patients with TP53 aberration compared to others. Cytogenetic complexity is another high-risk factor associated with CLL. It is defined as presence of 3 or more chromosomal abnormalities, and it is also an adverse prognostic factor in CLL in the presence of TP53 mutation. And then there is 5 or more chromosomal aberration, which is known as high cytogenetic complexity. It has got an independent prognostic impact on CLL patients. The current NCCN guideline define high-risk CLL based on these risk factors like TP53 mutation and IGHV unmutated status are associated with high risk. Among the surface markers, CD38, ZAP70, and CD49D are associated with aggressive course with a poor survival rate and poor and then increase and it has also a role in predicting treatment response. Among the cytogenetic factors, 17p deletion is the worst prognostic factor, followed by deletion 11q. And complex karyotype with 3 or more chromosomal abnormalities, another high risk factor for CLL. So to summarize, deletion 17p, deletion 11q, and unmutated immunoglobulin high variable status have worse prognosis. Other markers like CD38, SAP70, Notch1, beta-2 microglobulin are also associated with high risk. The National Prognostic Index scoring system can be clinically used to determine prognosis in CLL patients. And the current NCCN guidelines define mutated TP53, unmutated IGHV, deletion 17p, complex karyotype, etc. as prognostic markers in high-risk CLL. So with that, I complete my talk. Thank you for your patient hearing.
You're on mute.
You're on mute.
Sorry. Yeah. So thanks, Dr. Lata, for the excellent presentation. And now I would like to go for the next speaker, Dr. Mobin Paul. And I would like to proudly say that he is one of the person in our CH group, very active in arranging the academic meetings. And through him, we were able to sail through most of the academic meetings with his presence. And this time also, he is the one playing a main role in arranging this meeting. I would like to thank him for that. And you can proceed, Dr. Mobin.
Good evening to all. Thank you for the introduction, Swami sir. This presentation, I will try to go through how we manage CLL in India. We all know CLL is the most common leukemia in the West. It almost accounts for 25 to 30% of the cases. Relatively rare in East Asia and Sub-Saharan Africa. Age-adjusted incidence of CLL is in Europe is around 4 per 100,000 patients. Incident CLL, as per the data from Dr. Pankaj Malhotra's group, is 0.41 per 100,000, approximately 10 times lower than US. I'm just briefly going through the CLL International Prognostic Index. The variables we looked at are age, clinical stage, beta-2 microglobulin level, IGHV mutation status, and TP53. In it, high risk usually we treat except when the patient is asymptomatic. So, and very high risk usually advised to go for a non-toxic, non-cytotoxic treatment through a trial-based therapy. So these are the indications for the initiation of treatment by international working group. Most of the indications are progressive marrow failure, massive progressive symptomatic splenomegaly or lymphadenopathy, progressive lymphocytosis or a rapid doubling time less than 6 months, autoimmune complication of CLL which are poorly responsive to corticosteroids, or symptomatic extranodal involvement like skin, kidney, lung and spine, or disease-related symptoms like unintentional weight loss, more than 10% over last 6 months, or significant fatigue, or continuity of fever without any evidence of infection, or night sweats more than 1 month without any evidence of infection. This cartoon is already put by Dr. Nitin. This is how the treatment evolved, treatment evolution of CLL, early 60s and 70s with the use of alkylating agents or wait and watch policy was adopted. Then purine analogs came in. In 2000, purine analog with alkylators combined. Later in 2005, chemoimmunotherapy came in. Later, TKIs and monoclonal antibodies like obinutuzumab and ofatumumab came in. This is a recommended treatment regime. It's already discussed. Usually looking at the deletion 17p or TP53 mutation status and stage or the activity of the disease. So I'm just going through this. This is how relapsed refractory CLL is managed. When it's progressed beyond 3 years, we can try the first line therapy, or we can go to the refractory regimens based on the performance status of the patients. In the role of allotransplant in CLL, high-risk CLL, HSCT is considered the treatment of choice for eligible patients with high-risk CLL. And it's a modality have a curative potential. It has a 15 to 30% non-relapse mortality within first 2 years and 25% of chronic GVHD, which can impair the quality. So high-risk CLL, relapse refractory, usually novel agents can be tried. A response, we get a response, we can continue the novel agents if patient's disease is considered as a low disease risk or a high transplant risk like old age, significant comorbidities, or a mismatched donor. HSCT can be considered in case of a high disease risk or a low transplant risk like younger age, no comorbidities, and well-matched donor. What Indian approach? What is the Indian approach in CLL? So we usually do a baseline hemogram and immunophenotyping of peripheral blood lymphocytes for confirmation of the diagnosis, and history and a clinical examination along with the performance status to be assessed at initial evaluation. And we always get a CBC and differential count. Marrow examination is done when cytopenia is unclear, and additional tests need to be done before initiation of treatment, like a molecular cytogenetics FISH or TP53 mutation or IGHV mutation status, along with the serum beta microglobulin. Epidemiological estimates of CLL in India, as per the data from the PG Chandigarh, rate per 100,000 is 0.14 compared to United States at 3.32. And prevalence, as mentioned, low prevalence of CLL in Indian population, reason we don't know exactly. But in presentation, what we see here is different compared to West. Younger age, more aggressive codes. So based on the this real-world study, CLL patients in India, usually asymptomatic patients were kept on observation. Treatments initiated usually as per international work group criteria. Usually fit patients with reasonable financial resources usually treated with BR. Unfit patients with financial resources usually get R plus chlorambucil. Without results, chlorambucil with prednisolone. Fit patient with financial resources and good supportive care, FCR are usually considered. Patients with the deletion 17p and reasonable financial resources, ibrutinib can be considered. These are the data from PJ group. They have a median follow-up of 32 months. 70% of the patients lost the follow-up. Rest of the treatments which they used, commonly used as chlorambucil is prednisolone. That's used almost 50% of the patients. And the other, this shows the treatment outcome and toxicity. So treatment, time to next treatment with the first line therapy, chlorambucil plus prednisolone, usually it was around 33 months. The oral survival, not much of difference. And the trials on chemotherapy in CLL. This E2997 trial, this compared fludarabine with cyclophosphamide, fludarabine alone, and with fludarabine cyclophosphamide. This showed in combination improves the overall OR and CR with improved PFS in previously untreated CLL compared with fludarabine alone. It was not associated with the increased infectious toxicity. And this is CLL-8 trial where they looked between FCR and FC. So there was a definite benefit in PFS, and long-term data showed chemotherapy with FCR improves the PFS and OS in patients with CLL. And this CLL-10 trial, they looked at the FCR versus BR in advanced CLL. So this trial concluded as compared with the BR, FCR increases CR rate and the median PFS, but not OS. But FCR caused more increased adverse events, including neutropenia, thrombocytopenia, and infections. BTK inhibitor, ibrutinib, this RESONATE 2 is compared ibrutinib with chlorambucil. It shows definite PFS improvement, and longer the time, depth of the response was better with ibrutinib. Safety warnings usually are more commonly seen as diarrhea, and diarrhea was more common compared to chlorambucil. And common other problem was atrial fibrillation and bleeding. This is an NCCN updated 2021 update to go ahead in frail patients or patients with without significant comorbidities. Conclusion: upfront regimen, choice of regimen is chlorambucil with prednisolone, BR and FCR, or ibrutinib in our setting. CLL is marked with heterogeneous presentation with indolent and aggressive forms. Diagnostics play a crucial role in the management of CLL since presence of mutation, T53 mutation and unmuted IGHV status renders traditional chemotherapy ineffective. That study has shown that prevalence of high-risk features to be more common in Indian population. The use of chemoimmunotherapy is steadily declining, giving the better profile with the novel agents. Management of CLL in India is often hampered by unavailability of uniform therapy across the country and unavailability of newer drugs in Indian market. Thank you.
Thank you, Dr. Mobin. So, hope Dr. Nitin will be having some more time to share with us. And in that case, we can proceed for. Thank you very much. So, actually, the next session is the discussion on the frequently asked questions on the second generation TKI, but still we are yet to use in our common clinical practice. So probably before the, rather than that, some of the questions in the chat boxes we can discuss, followed by the questions if it is arising, then we can proceed. I'll start with the questions in the chat box. The first question is from Dr. Roshni. Is angioplasty or recent angioplasty is a contraindication for BTK, either temporary or permanent?
Not specifically. I mean, I guess the issue with the BTK inhibitor really is the risk of bleeding, right? I mean, that would be something, if you're on double anticoagulation, aspirin and Plavix, and then you add a BTK inhibitor on top of it. So I personally try to avoid either a dual antiplatelet with BTK or aspirin and an anticoagulation like oral anticoagulation with BTK. So if you have a recent stent and the patient is on aspirin and Plavix, so that's something I personally would try to avoid, because at least in the United States, we have venetoclax available for these patients. So we should be able to use that rather than to subject them to the risk of bleeding complications. I would say that before the venetoclax was approved or was routinely available, we were using dual platelets with the ibrutinib at that time. But again, the risk of bleeding remains. So I don't think there is a contraindication per se, but I personally would try to avoid if the patient is going to be on a dual antiplatelet agent.
So in the context of the bleeding manifestations, what about the newer anticoagulations? Suppose keeping aside the antiplatelets, if it happens to be a single antiplatelet with the dual anticoagulations or any other anticoagulation alone? What is your choice on that?
Yeah, so again, before venetoclax was available, there was no other option for us, right? I mean, in that case, we were putting these patients, if they were on aprixaban or rivaroxaban, and they were on aspirin, and then because that was the only thing available, a BTK inhibitor. Now that there are choices, I personally would avoid in my practice to put a patient who is on anticoagulation, this is my opinion, on a BTK inhibitor, just because the risk involved is there, and we have a potential safer option of venetoclax. Now, if you have a patient who has failed venetoclax or somehow has high creatinine, significant amount of tumor burden, you are worried about tumor lysis syndrome, I think it's okay to use, realizing that there will be a higher risk of bleeding for those patients. But let's suppose in the context of India, if you have for some reason availability of a BTK inhibitor for a patient has deletion 17p, yes, I mean, I think risk benefit that patient, even if they're on anticoagulation, you proceed, because that's what really the best therapy for that patient is. BR or something is going to lead to a short lasting remission. But if you have options available, if I have a choice between venetoclax in that situation, I would say go with venetoclax, because why to subject a patient to a potential complication when you have venetoclax, which doesn't have that issue.
In that case, if there is only BTK is available, if acalabrutinib started getting available, will you prefer over that because of the less bleeding risk and other things? Even then, the risk is still.
Yeah, so I mean, I in my practice, I have actually stopped using ibrutinib. I have not prescribed ibrutinib for the last couple of years since acalabrutinib came to the market. So if a patient, so really the options I discuss with the patient, I tell them, yes, there is ibrutinib, but it's more side effects, more atrial fibrillation, more dose reductions. And so I have not prescribed ibrutinib myself for the last couple of years. Everyone who wants a BTK inhibitor is getting acalabrutinib. So yeah, so if it's a clear choice of a BTK inhibitor you want to use, I don't see a real reason that, I mean, and if you have access to both the drugs and everything is being same cost and whatever access, there is no reason to use ibrutinib. Patients should receive acalabrutinib because it's certainly a safer BTK inhibitor.
Thank you. The second question is from Dr. Rajesh. Even though you have stopped using for the last 2 years ibrutinib, we are still in the ibrutinib era because of the financial constraint. So what are the most important causes for the ibrutinib discontinuation? Is it the grade 1 events like simple musculoskeletal events or the severe ones?
Yeah, I mean, so I think obviously the grade 1 and 2 events are common. So majority of the patients will have arthralgias, myalgias, so those typically, I would say, doesn't lead to discontinuation of ibrutinib, but can lead to dose reductions. So you can drop to 420 to 280. I have many patients on 140 as well, few occasional patients on 70 milligram daily as well. So you can manage those grade 1 or 2 side effects by dose reductions. Rarely, I would say that those grade 1 or 2 side effects lead to dose discontinuation. The main reason for discontinuation has been, I guess, atrial fibrillation, severe infections where patients is getting into, may not be related to ibrutinib per se, but I mean, if suddenly someone has a fungal infection, which have been associated with ibrutinib, PJP, all those things. But atrial fibrillation, I think, is something which is a common reason for ibrutinib discontinuation in the clinical practice, because that also then, if a patient does atrial fibrillation, then they may be on an anticoagulation for their AFib. Then that adds another layer of this discussion we were having, where then to reintroduce ibrutinib, you may be having more episodes of atrial fibrillation, and then the patient is also on an anticoagulation, and then you are increasing the risk of bleeding. So in those situations, I myself these days, if a patient develops atrial fibrillation, and many times if the patient has been on a like 2 or 3 years remission, they're doing well on ibrutinib, their disease is beautifully controlled, I actually just hold their ibrutinib and see what happens. And you can actually, there are studies being done now that, if because I have patients, and a lot of us have patients where you have done ibrutinib for a certain number of 1 or 2 years, 3 years. A patient develops a complication, you stop it or hold it. You see the patient a month later, they're fine. 3 months later, they're fine. 6 months, and that can go on for a few years. So what I'm trying to say is that if a patient develops a complication, if the disease is beautifully controlled, I may just hold it, see what happens. But if the time comes that we have to resume the drug because their disease is flaring up, I may consider, again, a venetoclax-based strategy in that approach. You could reintroduce ibrutinib certainly, or certainly if I reintroduce ibrutinib, I will lower the dose of the ibrutinib in that situation.
Thank you. In the same context of atrial fibrillation, incidentally, on a routine clinical practice, we detected the atrial fibrillations, and the patient is absolutely asymptomatic, and the cardiologist have been called for, and they have added on rivaroxaban to make us complicated, and the patient is asymptomatic through and through for the next 1 week. The question is whether to reduce the dosage, whether to continue the medication, stop and restart, and the rivaroxaban in an asymptomatic patients.
Yeah, so that's a tricky one. So I think in that situation, the guidelines will say for the first episode of atrial fibrillation, you reintroduce at the same dose. If it happens again, then you lower the dose to 280. If it happens again, you kind of 140. In my practice, again, what my practice was, I would say, when we're using more and more ibrutinib, is that even with the first episode, I will drop the dose to 280 milligram. Now that decision may also come into play. Let's suppose a patient is within the first month or 3 months of their treatment and they had a significant amount of disease. Maybe there is some concept of maintaining the dose intensity early on before you kind of drop the dose, because as you may know, there have been a lot of data of lower doses of ibrutinib maybe equally effective and things like that. But there is something to be said about the dose intensity early on. So if a patient had atrial fibrillation early on and lots of disease, I may resume the same dose thinking that maybe the disease needs help right now with the full dose of ibrutinib. But let's suppose patient is 1.5, 2 years out of it. Their disease is very great partial remission. They develop an atrial fibrillation. Then I'm much easier to drop the dose to 280 because I know that hopefully their disease hopefully they don't need that much ibrutinib. But that's just there has not been a head-to-head trial, nor there ever will be, of a lower dose of ibrutinib versus standard dose of ibrutinib. But I think those are some of the things I think about.
Thank you. One of the questions is regarding the MRD from Dr. Deepthi Rani. What is your opinion on the Activate trial having a joint MRD in the peripheral blood as well as in the bone marrow? Is it both combination is required because the concordance around 86%? So what is the inference on?
In the Captivate study, you said?
Yeah, that's correct. They have mentioned, Dr. Deepthi has mentioned that. Activate. Probably she mentioned Activate.
Yeah. So MRD, I think it's really, it's still a big debate whether MRD has role in CLL or not. Certainly it has no role in if you're using ibrutinib or acalabrutinib, there's no role for checking MRD because these patients will never become MRD negative. You're just, it will always be positive. MRD can only come into play really if you're using chemotherapy or you're using venetoclax-based therapy, whether it's venetoclax plus rituximab, venetoclax plus obinutuzumab, or if you're using venetoclax plus ibrutinib, which unlikely, at least right now, you'll be using in Indian setting. And there, the question is, which is a better disease site for MRD monitoring? So what it appears so far is that if you're using chemotherapy, it appears bone marrow is definitely a better site than blood for MRD monitoring. But if you're using venetoclax-based therapy, the concordance rate is 86 to 90% range, which is actually a pretty good concordance range. And certainly bone marrow, doing a bone marrow MRD assessment, all those things, invasive procedure. So I think the field itself is moving towards a peripheral blood MRD for evaluation rather than subjecting the patients to bone marrow. A CLL14 study, most of the treatment decisions are when they stop the therapy at 1 year, and all the data they have shown about MRD and then subsequent progression is really based on blood MRD monitoring. At our center, we do much more bone marrow MRD monitoring, but more recently, I would say in the last 1 year or so, we are shifting to also using more and more peripheral blood MRD as opposed to doing bone marrow MRD, because I think at the end of the day, peripheral blood MRD is quite yes, you may miss few patients here and there, but on a practical front, this is not like an ALL patient where MRD presence is impending for disease relapse in the next few months. CLL patients with MRD, I mean, they do fine. I mean, they will do fine for the next few years. So I think there's a less of a, MRD has, in that sense, less of an important role as opposed to what role it has in B-cell ALL for that matter. So yeah, so we are using more and more blood MRD for patients as opposed to bone marrow MRD.
Okay, so thank you. The Dr. Mukesh question on the MRD has been addressed very clearly at this point of time. So Dr. Deepti again asked this question on the hepatitis B flare-up in the acalabrutinib.
So, I mean, we routinely check hepatitis. This is part of our standard practice to check hepatitis, HIV for patients starting any therapy of CLL, not just acalabrutinib, venetoclax, antibody therapy, CD20 antibody therapy, chemotherapy. So certainly there has been reports of flare-up in the context of, I'm not sure if, I'm sure there are reports in the context of acalabrutinib, but there are certainly reports in the context of ibrutinib, obviously in context of rituximab, obinutuzumab, that if you have active hepatitis, it could flare up. If you had a previous exposure to hepatitis, it could reactivate. So there has been this thinking of, using prophylaxis for hepatitis B with the entecavir and things like that for these patients. So I mean, I think certainly that's something you should check in your practice before you're starting acalabrutinib for your patients.
Okay, so Professor Dr. Pranab Kumar Bhattacharya from University of Calcutta asked two questions. One is regarding the inheritance. That is, does hereditary factor plays a role in the etiology of the CLL for the first degree relatives? And the second question is, the several large studies showing the genetic alterations in the CLL, including the SNPs, chromosomal alterations, and the alterations in the non-coding RNA and microRNAs, some of which can be used to determine the prognosis and to guide the treatment strategies. View on yours.
So in terms of the familial CLL, this is a topic which has been studied to some extent, but not a lot of work has been done. There's certainly a slightly increased risk in the first degree relatives of having CLL, but it doesn't imply that you should be screening family members with a flow cytometry in the peripheral blood if someone has CLL. That is not the practice. The risk still remains very low. There are certain mutations, SNPs, which have been described. There are certain mutations like a POT1 mutation, which has been associated with familial CLL. So yes, I mean, I guess, but at the end of the day, I think it's not something I personally have not investigated much, nor that most centers are doing right now to look specifically at familial CLL, as familial MDS and all those other things have gone along in terms of the research paradigm. And yes, so there are mutations which have been described in the introns and the non-coding RNAs and other things. Some studies have shown that they have some prognostic implications. Again, on a routine practice, on a clinical practice level, we are not doing those studies, and most centers are not doing those studies to look at the mutations in the SNPs or mutations in the non-coding regions of the genome. But again, those are things which eventually will be done. But from a clinical standpoint, I don't know what their relevance is. The only mutation I would say which really matters from a clinical perspective right now is the TP53 mutation. But certainly there are other Notch1, SF3B1, BOG3. Those also we routinely check for our patients. But again, this on a treatment decision-making standpoint, what really matters is the P53. Everything else, I mean, we check it, but we don't really make decisions based on Notch mutation, for example, per se.
Thank you. Last couple of questions. One is from Dr. A.K. Tripathi. What is a safe platelet count to start the ibrutinib therapy? And from Dr. Vinayak, another question is, how common Richter syndrome in CLL? I don't know, he didn't mention any, whether with BTK or without BTK. These are the two questions.
Yeah, so the safe thing with platelet, I would say that the clinical trials which have been done, I think the cutoff they have used many times is 25 and 30, something like that. But certainly if a patient has a platelet count of 10,000, I probably will not initiate ibrutinib right at that time. For that patient, if you have to think maybe it's ITP or something, or if it's just the disease related, probably give Rituxan or obinutuzumab steroids, try to control the disease a bit better before you initiate ibrutinib, get the platelet count up. I would say at least 25-30 range before you initiate ibrutinib for a patient. In terms of the Richter syndrome, that's a big topic in itself. So occurs in around 5% of patients with CLL. It's a tough disease. Median survival is less than 1 year. Historically, chemotherapy such as R-CHOP, EPOCH-R, those have been the standard to use. We are now using venetoclax, as venetoclax is being used for everything else. We are using venetoclax now with chemotherapy. So we have a trial with EPOCH-R-VEN. Also, we have a trial with R-CHOP-VEN. We also have a trial with venetoclax plus a checkpoint inhibitor. We have done some work with ibrutinib plus checkpoint inhibitor, which have been published. So I think these are the patients which are a tough scenario. I think in the context of India, you probably will end up treating them like a DLBCL, give them R-CHOP. But I think adding venetoclax probably is a good way to go for these patients if a patient can afford it. And then the goal should be an allogeneic stem cell transplant. These remissions don't last long. So I really should, if a patient is of transplantable age, to go for a transplant in this setting.
Thank you so much. Thank you so much. And we come to the last session. That is the expertise management of the CLL in a case-based discussion. And if Dr. Nitin, if your time permits, please join us and enlighten us in our knowledge. And
can I?
Thank you. And anytime yeah, go ahead. Go ahead, Chipsy. Go ahead.
I just wanted to ask Nitin two practical points that I just wanted to know from him. One, it is intriguing that you've all moved away from chemoimmunotherapy, while we are still, that is the standard of care here primarily. I just wanted to know, in case like when we have the steroid unresponsive autoimmune complications, in that scenario, is there a preference of which drug to use other than your deletion 17p and all that amongst the chemoimmunotherapy versus BTK or BCL2? What would you prefer?
So I would prefer a BTK inhibitor. I don't know if there is much data with venetoclax in that setting in the context of immune hemolytic anemia. I typically do steroids. I generally do steroids and rituximab together for these patients. If it's a first episode, you do steroids, rituximab, they generally improve. And I just watch them at that time. If it recurs 6 months, 12 months down the line, in that situation, I do steroids, rituximab again, get their disease control, platelets count up or hemoglobin up, and then start them on a BTK inhibitor. And again, it could be either ibrutinib or acalabrutinib for that matter. I haven't used venetoclax in that specific situation. I don't know if there's a data with venetoclax in that situation. So I have more experience have been with ibrutinib or acalabrutinib in that role.
Thanks.
Thank you. Anybody else is having any questions?
So when you place PI3 kinase,
yeah.
I will do, so I have to leave in a few minutes. I have another competing call coming up shortly. So you guys can carry on, but I may switch off.
Yeah,
but
anytime in between you can lay off. Thank you very much. Hoping that to see you again in our online meeting, if not possible in person in the near future.
Sure, absolutely. Looking forward to it.
So
and maybe I can answer this quick question someone asked about the PI3 kinase inhibitor before I go. So PI3 kinase inhibitors, the role has become quite limited. The efficacy has not been as great as a BTK inhibitor or venetoclax. And so we have, and the side effect profile, is with immune colitis and whatnot. So we are actually using it really as a third, fourth line options after they have failed a BTK inhibitor or failed venetoclax. If they're not going for a CAR-T for some reason, then that's the option we may consider. But I think it's the role is extremely limited. I have very rarely actually used PI3 kinase inhibitors. All right, thank you everyone. I'll switch off. Have a good night. Stay safe. Bye.
Stay safe. Take care. The last session is our case-based discussion, and unfortunately, Dr. Chandran was not able to join with us. And instead of that, Dr. Manojuni is leading us on the moderating sessions. And Dr. Chitresh from Amrita is presenting the case. And our panelists will be Dr. Mobin Pal, Dr. Chepsi and Dr. Shinto, and if time permits, Dr. Nitin may join us. So with this, Dr. Chitresh, it's yours.
Good evening, everyone. Myself, Dr. Chitresh. I'm a first-year PG resident in DM Clinical Hematology at Amrita Institute of Medical Science. At the outset, I would like to thank organizers for giving me a chance to present the case in such a esteemed conference and in front of all the great faculties. And to myself is also present Dr. Manoj Junni. Coming to the today's case, let's start. Patient named Mr. MP Joshi. He's a 54-year male from Ernakulam. He's a moderately built, middle-income man from he was working as a manager in a private firm in a Middle East. His present illness, currently he's a relapsed case of chronic lymphocytic leukemia on tablet ibrutinib. Coming to his clinical details as how the disease progressed and how over the year the disease evolved, we'll go back to the 2019 when he was incidentally detected as leukocytosis with lymphocytic predominance back in 2019 on incidentally on a routine blood checkup, where on initial investigation his hemoglobin was 14 milligram, total count was around 11,600 with predominance of lymphocyte, out of which 21% lymphocytes were atypical, along with many smudge cells. There was no organomegaly, no lymphadenopathy, and he was initially followed up irregularly by the general physician. Then, in view of persistent leukocytosis for 2 years, and now he developed neck swelling also, which was on the right cervical area, largest was 1 centimeter. He was evaluated further for the disease. And on peripheral blood flow cytometry in November 2011, at the 44 years of age, he was found to have CLL. At that time, his CBC parameters were hemoglobin 14.4, total count 13.5, and lymphocyte being 65%, majority of cells, with platelet and hemoglobin were within the normal limit. Peripheral blood was normocytic, normochromic, with predominance of lymphocytosis and smudge cells. On peripheral blood flow cytometry, on gating the lymphocytes, they were positive, highly positive for CD19, CD5, CD45, and HLA-DR, and they were moderately positive for CD23, CD11, and 20, and were negative for T cell markers and other markers like CD25, 22, 10, 34, kappa, surface immunoglobulins, lambda, and other markers. But on checking for CD28, it was 12% positivity, and ZAP70 was showing 21% positivity. A final impression of chronic lymphocytic leukemia B cell type was suggested on flow cytometry, peripheral blood. Other investigations on the initial diagnosis was on karyotyping. He was having the model karyotype of 46XY, which is normal. There was no cytogenetic abnormality on the fish. Lymph node biopsies of the upper cervical lymph node, which was positive for PAX5, BCL2, 23, CD5, and weakly positive for 20 with high Ki index of 30%. Features were similarly suggesting of CLL bar SLL. Serum LDH was within normal limit, and there was hypogammaglobulinemia. So coming to the prognostic parameters, he was a middle-aged male with comorbidities of hypertension, Rise stage 1 with lymphocytosis and lymphadenopathy, Bennett stage A with hemoglobin more than 10, platelet above 1 lakh, and less than 3 areas of lymph nodes were involved at the time of diagnosis with only cervical lymphadenopathy. He was only on the regular follow-up and observation at that time. Subsequently, for following him for continuously, there was on the CBC parameters in 2012 to 2016, his hemoglobin and platelet were within normal limit, and there was very little fluctuation in the hemoglobin and platelet count. But seeing the total WBC count, it was gradually increasing, but there was no rapid rise in the WBC parameters. WBC from 2012 rise from 20,000 to 44,000 in 2016, with lymphocyte being 56% to 63%. Then slowly the disease, in between this monitoring, he had subsequent malignancy. In 2014, he developed a midline neck swelling. On evaluation, it was found to have a papillary carcinoma of thyroid, for which he underwent a total thyroidectomy with central lymph node clearance and high dose radioiodine therapy. The lymph node were free of thyroid malignancies, but the 2 right cervical lymph node, which he also had during the initial presentations, were positive for CLL/SLL. Coming to some family history, he also had a strong family history of carcinoma thyroid to the mother, which was diagnosed at 64 years of age, also to the younger brother at the 30 years of age. Like all the patients of CLL, our patient was also not very lucky. He also had 2 infections in 2015 and 17, for which he was hospitalized. In 2015, he had left lower lobe fungal pneumonia, which was treated for almost 6 weeks with voriconazole, and later there was a clinical as well as radiological and cultural negativity, and then he was discharged. In 2017, he developed fever with blood culture positivity for Rhizoltelia monotilica, and then he was on culture report, he was treated with cephaprazone sulbactam for 14 days after the first negative culture, and then subsequently he was discharged. In February 2017, his lymphocytes shows rapid doubling within the 6 months. So a tumor board meeting held in that this case was discussed, and a plan was suggested to treat him with FCR regimen in 2017. He received 6 cycles of FCR regimen. Last was given in July 2017. He developed the first complete remission after the 6 cycles. His hemoglobin was 11, total count was 8,1700, neutrophil this time being the predominant one, with lymphocyte being only the 9%. Platelet was 1.5 lakh, and then he was on a regular follow-up. In 2018, he had again a relapse of CLL with total count rise to 97,000, along with a new lymph nodes in the submental region. But hemoglobin and platelets were within normal limit. A whole body PET CT was done, which showed FDGV, avid, supra and infradiagrammatic lymph node, along with bilateral cervical level 1B, 2, 3, and 4 lymph node, which largest being the 2 centimeter in the level of 1B, along with diffuse tonsillar swelling. There were no organomegaly this time again. Lymph node biopsy from level 1B again showed the features of CLL/SLL. This time he was planned to give 6 cycles of R-Benda, but unluckily after the 3rd cycle on November 2018, he developed skin lesions, which were bullous skin lesions, and on dermatological evaluation, it was suggested that it's a drug-induced lesions, with skin biopsy showing intraepidermal bulla and dermal deposits of eosinophil, likely drug-induced. And previously also he has taken 6 cycles of rituximab, this type also. So a drug of bendamustine drug allergy was suspected. He was started on steroids, completed treatment in July 2017 with resolution of the lesions, and the further doses of R-Benda was deferred. In 2019, he had a sudden platelet fall. We thought, is it a disease progression or what? But luckily, we found that it's a dengue-induced thrombocytopenia. Then the patient recovered from it, discharged, and he was on follow-up. Then the options of ibrutinib or allogenic stem cell transplantation was discussed, and patient wanted some time for the decision for the same, and he planned, and more time he wanted because he was going out of India for a longer stay for his work in the Middle East. As he was not able to take a decision for the disease, he was started with tablet chlorambucil 5 milligram BD 2 out of 7 days. That then the time of COVID pandemic first time came. He was on chlorambucil only for 2 months in the later half of 2019 without the treatment in the first 3 months of 2020. Disease progressed. This time in 2020, whole body PET CT shows bilateral supra and infradiaphragmatic lymph node with persistently diffuse asymmetrical uptake in bilateral tonsils, and also increase in the total WBC count with no organomegaly at this time again. In April 2020, he was started with, after cardiac clearance, he was started with tablet ibrutinib 420 milligram once in a day, and he was regularly follow-up. They were initially weekly follow-up were there of CBC, but to present the data, I have gathered the 2020 CBC parameter on which his hemoglobin and platelets were usually all the time since the diagnosis were within normal limit. As there was increased WBC count, the decision was to started with ibrutinib was taken after the starting from lymph node. As we all expect on ibrutinib, there were the peripheral pooling. Subsequently, the WBC started coming down. Later, like patient is currently on ibrutinib. After continuation of ibrutinib, he had 2 surgeries. First of eye, where he has a phacoemulsification for cataract surgery with posterior chamber intraocular lens implantation, and in 2021 he had left mastoidectomy with tympanoplasty. During this period, his ibrutinib was stopped for 1 week before the surgery and was discontinued 1 week post surgery to reduce the chance of bleeding. In April 2020, his latest CBC shows hemoglobin of 10.3, total count of 9,300, lymphocyte being 39% and platelet being 3 lakh, with CBC of normocytic normochromic anemia. In a summary, a 46-year male of, which was diagnosed as CLL with FISH negativity, had complete relapse for 1 year after FCR therapy, 6 cycles, then 3 cycles of R-Venda, which was truncated due to drug toxicity, failed chlorambucil metronomic therapy, then maintaining the complete relapse on ibrutinib since April 2000, since starting from April 2020 to 2021. Thank you.
Dr. Manoj?
Yeah.
Dr. Manu, you can go ahead with the discussions.
Yeah, thank you, Chitresh, for that presentation. So, can I see who's participating? So this case signifies that we could see right from the beginning how things went on throughout the starting from his asymptomatic stage till multiple relapses, as well as he required multiple chemotherapies. So, Dr. Chepsi, what would your view on this case?
Yeah, thank you, sir. So nice presentation, Dr. Chitrish.
Thank you, sir.
Well, welcome to the group.
Thank you, sir.
So I think it is a very practically something that we all see, particularly this flow that you showed earlier. It is very common that we don't see these typical features of CLL in all the flow. Like you showed, I think if I remember right, you gave a CD23 negative, FMC negative, CD22 negative, no light chain restriction.
Yes, sir.
I think it is common. I don't know, for some reason it is common in our practice that we don't get these typical features. If you typically follow the CLL IPT score, ideally it will not fit into your CLL. Ideally, but I recognize this. This is what many of us see in practice, and then we treat it as CLL. Sometimes we label it as CD5 negative, CD10 negative, or we have this. I don't know. Probably our uh, our diagnostics have to probably improve in diagnosis. So this is one. First, the diagnosis itself would have got us confusing earlier, and I'm sure after that we wouldn't have got a good diagnostics because he was exposed to many therapies. But practically, I think you've followed a great plan here. But personally, I am not yet started using BTK inhibitors. I would have probably strategized it as because the patient had responded to FCR earlier. I probably would have considered maybe a chlorambucil R in preference to chlorambucil alone if the BR was showing a drug allergy to bendamustine.
Okay.
I think practically that is the only other thing I would have thought of because I have issues in giving this drug. Otherwise, I think if I have all the choices, I probably would have followed the same strategy.
Yeah, but he was going to the Middle East, so we couldn't. They couldn't put the rituximab. He wanted to take the tablets and then go away from India. So the rituximab was just not considered because of his logistic effects.
Perfect, sir.
So,
I think it makes sense. Yeah.
Okay, so next, Dr. Sriraj, what would have been your way of approach for this case, which has been asymptomatic till multiple relapses and chemotherapy? Dr. Sriraj?
Dr. Mobin, Sriraj is not available at this time. Can you take it, that question? Sriraj, Mobin? Yeah.
How would you approach this case, Mobin, given the chance that he was asymptomatic in 2009 till 2021? Would you have a different approach, or what would be your algorithm for seeing this case in our setup we have?
Yeah, sir, I just wanted to clarify this skin lesions following bendamustine, which we often see when we use BR, maybe by third, fourth cycles, and it used to last, once you stop also beyond. Is that same kind of lesion, or it's like an anaphylaxis to bendamustine?
No, it was the regular bendamustine-induced itchy lesions, which we usually see by end of third or fourth cycles of bendamustine, and which persists for even after that. So, if this patient had very intensive lesions all over his body, and so one couldn't proceed beyond 3. In many cases, of using bendamustine in other diseases, we do use steroid cover and continue the thing, especially if it is a mild reactions. But for this patient, it was really difficult to proceed. So we had to stop it, after 3 cycles. It was a classical bendamustine-induced reaction, which our dermatologists are they are very experienced seeing and get diagnosed as early as possible.
This is the way we can manage it in our settings, sir. Just manage it very reasonably, appropriately.
Sure. So
this is before initiating ibrutinib, we regularly do, get involved with the hepatologist to look at the liver status.
Yes, we get the hepatitis workup done. We also proceed for cardiology workup, and we especially discuss with the patient about atrial fibrillation. And then the cardiologist also tells about the pros and cons of this. So they're very well aware of that before they start ibrutinib. We also get a hepatitis C antibodies as well as the pre-op serology workup done before actually initiating them on ibrutinib. And if there's any something like that, then before any rituximab or anything, we definitely get a hepatitis workup done. If necessary, get a cardiology, gastroenterology involved in that.
I use this 140 mg for child CLD, and they do very good with this 140. So anybody reduce the dose in your financial constraints?
No, this patient could, even now he's able to afford the same tablets. So we don't have so many on, I think 2 or maximum 3 people on ibrutinib, and they're doing on their own. One is, I think, on insurance, and other people they're doing it on their own. But they're not being. We don't have to reduce any dose as of now.
To the Mubin's question, I have a patient with the CLD with the hepatitis B flare-up on ibrutinib, along with medications as well as with the ibrutinib, and the full dose is being continued, fortunately. But he is compensated liver disease, mild derangement of this one without prothrombin affection. The albumin was relatively preserved with the AGOTPT around the 60s range, but he is continuing. Touchwood for the last 7 months is doing fine.
Is it okay? Okay.
You are asking about the child score regarding CLD.
I was giving them once a day.
Regarding the ones no, in fact, I am full dose. I am giving it with this one. There was no problem. That's what I would like to say.
Okay, so Dr. Deepak Chaj is here. So what would he suggest? How you view this?
No, he is not available. Instead of that, Dr. Shinto is there, and Chepsi can take over. Dr.
Shinto, what would your approach be, and would be different or something, or same, or how would you view this? Such a case with the long-standing durations.
Yeah, as Dr. Chepsi said, this is an unusually typical CLL, textbook kind of CLL. So I agree to that. One thing I would have done is do a repeat fish at the time of the at least at the time of change to ibrutinib, because this is some idea which I got implanted from Dr. Maman sir. He had stressed on this repeat fish and to see the biology, why it has gone. It's not that typical at that stage. So do a repeat fish, probably maybe the last relapse, not in 2017, maybe when the switch to ibrutinib happened, a fish could have been done to look because the earlier was negative, whether it is 17 HP. That's my only suggestion.
Yeah, that's right. That I agree with Dr. Shinto saying that as the new guidelines also says that before any start of any new protocol, we should do a fish to see if the progression or worsening of the parameters. That is there, yes. But this is quite rare disease, and these algorithms are yet to sink in. Thank you, Shinto.
Manoj, for the question contained in the context of Dr. Shinto's question. Now, repeat fish, even if you are doing it, we may pick up the routine what we are expecting. But
yes.
Still we are missing it. So the problem is we are end up in using the entire 57 genetic leukemia genetic markers. And is there any way we can tune it for 1 or 2 gene markers anybody is doing, like for a CLL P53, something like that? If not SF3P or something like that, only P53, anything? That I think we need to look into that, because now the protocol says that P53 is a must, whether it is initial or relapsed when you are thinking about it. And we are not doing it because it's not necessary that it will pick up.
I'm not sure they're doing separately one, but then mostly it's panels what they do, and then that cost exceeds. But then I think that's fine, because so for routinely we've not been doing everybody because of probably the large panels which is involved.
Even some of the people are saying that even the leukemia genetic marker, the P53 may not be sometimes picked up all the time. Something they were telling that. I'm not sure about that. Shinto, anything on that information? Like when we are doing that leukemia genetic marker 57 P53, sometimes will it pick up all the time?
No, we do as a generic package kind of this genome, not really looking into specifics of anything.
Like FLD3 may not be picked up, something like that.
I have a question to my panel members. Whether if it's a stage 0 RAI, in a stage 0 RAI, asymptomatic, so is baseline fish done by everyone, or if say it is a stage 0 fish 17p is positive, is there any indication to treat? Not really, right? So
no.
may not do
Absolutely. When you are not stage 0, when you are saying it, we are not going to treat it. When you are not going to treat it, we are in Indian scenario, not in a research institutions. We are not going to do that.
Yeah.
But again, the handicap is that even when you are doing the fish, we are not doing the P53, which is a must.
Yeah.
In the current scenario, that is the reason.
Sir, it is not that we have to do the P53. Probably the practical approach would be like what we are already doing. Fish you get and do. And only in cases which fish is going to miss, probably the role of, because cost is really an issue. Because P53 is only to catch those small subset of patients who are actually 17p deletion negative, but still might have a P53 mutation.
Absolutely. Absolutely. The second thing is, in the same context, karyotyping, I have not done for the CLL. Now, we know that the complex karyotyping 3, 5, Dr. Lada lucidly narrated, but anybody is doing the karyotyping in a bone marrow. As such, we are not doing the bone marrow when you are not going to treat the patient. Even if you are going to treat the patient, we are going to do the fish, which is be done invariably in the peripheral blood. And the cytopenia, if it is not a DCT positivity, we are going to attribute to the disease process in general. Of course, we may have to do that. But what my question is that, are we doing the karyotyping for any CLL patient? But we know that complex karyotyping, all other things.
We are not doing so.
I'm not doing it. I'm not doing it. That's what I'm just doing for the fish, and then we're getting away with that. So that is the thing.
Practically, the option is either BR and seriously.
No, but actually, because of when I was in Gulf, actually they were doing a FCR, because majority of the time Gulf countries will follow the UK-based protocol most of the time. So UK people are fond of FCR-based regimen. If you talk anyone from the UK, they will say they will insist on the FCR. Whereas in US, they are comfortable with the BR-based regimens. So I am not seeing after coming here, probably Manoj and anybody can say that FCR is the one which will be used left and right. But after coming here, that BR is the one which we are using it on this one. Of course, FCR most of the time, it does have a problems, and of course, neutropenia, cytopenia, future MDS invitation, everything is there. And especially what we have seen is when it is crossing the 4th or 5th cycle, when the cytopenia prolongs, when the patient does have not able to complete the 6th cycle, probably that may be the incidences which we can think about it. But otherwise, Manoj.
Yeah, the young people who are fit, I think the last few years we did give FCRs, and the later cycles had really quite severe neutropenia, which lasted for a long time. I think the 5th and 6th cycles we had to actually, I think the last we had dose reduce actually because of the severe neutropenic prolongation. They were young actually, they were in the 40s and early 50s, but then beyond it, we had to go beyond only for R-Benda. And that of course is doing very smoothly with people. They're doing very well. I think in the process of treating with the FCR and R-Benda, when now with the ibrutinib has come, it's still yet to sink in. Acalabrutinib takes even more time. The FCR and BR, because we get biased towards BR because of the lesser toxicity and less chance of sepsis. But again, having said that, we have given FCR for the younger individuals, and they're still on follow-up and they're still doing well. So it's toxic, definitely. It's only towards the end, last 5 or 6 cycles, the 5th or 6th cycles, they become the problem. Neutropenia actually sinks in, and neutropenic periods prolong more than what is actually mentioned in the protocols. So yeah, we have been.
Anybody is doing IGHV mutations now? Till now, we are just going with the CD38, even though there is no concordance 70-30% or something like that. But anybody like IGHV, Manoj, being the institutions, anything on a protocol theoretical research?
No. We're not been doing that specifically.
But the company is coming out with the some of the companies are coming with doing this one. not sure whether they.
Magino people are doing. They have the CLL fish panel having IGHV, P50, 17P, and I think 11 and I think 13. Notch, I'm not sure.
They have.
All markers I think they're doing that has the IGHV. That they're doing,
What are the 3 markers?
I think IGHV, 17P, 12, and 11Q. I think 13 also they're doing, because fish myeloma also they're doing 13 and all those things. So IGHV, I remember doing that. I have to check. I think they're doing.
They're doing molecular panel with the notch, IGHV, this the P53 and
SFT3P and other things.
YDD 4-5. I am not used.
Manoj?
Yeah, I think that's it. I don't have much more to say, because it's not that we have lots of cases. We have a few are still on follow-up, actually, asymptomatic CLL. They are still on 3-monthly, 6-monthly follow-up. But then a few of them have post-FCR, some of them are post-Benda, and then 2 or 3 are on ibrutinib. So that's all our CLLs are all about.
Anyone use ibrutinib for low-grade relapse lymphoma in elderly?
No.
I have a few.
Please share your experience.
No. Very old people, mantle, third relapse, then splenic marginal zone, 80-year-old. Actually, low-grade lymphomas, either single or combined with the rituximab, they are doing fine actually. And 2 are there on, like CLD with the 140 mg OD. Those guys also doing fine. I mean, like almost some 8-9 months time now. So I used it for aggressive lymphoma, few patients, but I guess it can't pace the growth of DLB still. I mean, like when we can't give injectable chemos, elderly people, when they relapse, high-grade relapses, 2-3 patients we tried, we didn't work out. But it's low-grade outside that recommendation, it's very elderly people with reasonable performance status can be tried.
I have a case of mantle cell leukemia, 79-year, ibrutinib, and is tolerating till now, no problem, full dose. In fact, I am going for 4 tablets, like a mantle cell lymphoma. And he had the one asymptomatic on a routine clinical examination, which I have put it forward that this one atrial fibrillations. So now we are giving a 3 now. Well, I'm a bit scared.
That's interesting.
Manoj, anything?
If I am not yet, I don't know. And people on this had acute MI, they put on dual antiplatelet. Those days, not much of bleeding. Then one patient had a mediastinal, just like nodes which biopsy proved to have TB. TB reactivation was there for one mediastinal EBUS biopsy, another had a intestinal granuloma, which we thought initially was beta-hepatitis disease, but biopsy was granuloma. 2 patients.
Regarding this particular case, in view of this infection association with the ibrutinib, he had some fungus infections. He was treated with the oriconazole in the interim period. So being put on the ibrutinib, as we have some of the cases has been studied that there was a flare-up of the fungal infections. So probably we may have to put on antifungal and dose reduction caveat. Something has been thought about it.
Yeah, there's no dose reduction, Ramaswamy, for this. He had a fungal infection in 2017, 2 or 3 years ago.
That's correct. 3-4 years back.
Yeah.
Having set the history, So they are, even that time he didn't have any medication, even he didn't have any chemoimmunotherapy. That point of time he had the infection.
Yeah.
So all the more when he is put on that, there is a chance of flare up of the fungal infection being the common source. So probability of adding some antifungal with the dose reductions of ibrutinib.
Yeah, there was with
the antifungal.
He's not
that
an
time
Indian, he's only
Oriconosol. That time Oriconosol.
No, yeah.
Now
only
he is
that
not
time.
on it.
He was seen by infectious disease department and they told there is no more need to do anything, and he has been asymptomatic since then. He never had any problem after that. He after that almost 2 years have passed. Now he's ibrutinib since almost a year. He never had any issues with ibrutinib also. He had this cholesteatoma in the in the ear, for which he underwent a surgery just 2 months ago, and that was anyway more of infection. There was no evidence of any fungus in that or anything else. So that was the prime reason we had stopped a week before of the surgery, ibrutinib, and we started a week after. But then there was no infection complications at all for the most the 1 year he was on actually on that. But of course, we have kept it in our sight that he had a whole history of fungal infection. So we haven't started any prophylactic fungal as yet. He didn't have any problems at all for the last 1 year.
He mentioned hypogammaglobulinemia, but what about the current gamma globulin status? Because he had a mastocytitis, unexplained mastocytitis. Why should you have it? So
IgG level is slightly low, but IgM, IgA is normal.
IgG is
530, slightly lower.
So maybe the reasons.
Issue, right? FACO emulsification, something was done. What was that?
Eyes, for the cataract.
Okay. Because ibrutinib can cause something called a cystoid macular edema, which we had published from Rajiv Gandhi.
Okay.
So this is not that, I believe.
No, this is not. This was basically he had the other major surgery was the cholesteatoma.
Okay.
Right. If any questions to be discussed? Okay, if there is nothing left out. So thanks once again, Dr. Chitresh, personally as well as from the CSG forum perspective, and hope we can continue to enlighten ourselves each other in the coming days with your leadership, like Dr. Manoj and everyone. Okay, so hoping to see you for the next presentation in the near future, if one is being arranged by active Dr. Mopin. Shinto, nice to see you after a long time as well as Chacha. So take care, stay safe. Bye. Winding up at this time. Thank you very much for all of you being joining with us. Once again, personal, even though in his absence, I would like to thank Dr. Nitin for his valuable time in the early morning to come with us and enlighten our knowledge. Bye.
Thank you.
Thank you. Thank you.
Bye.